Today, we'd like to kick off Waltz Mental Health Moonshot series with our interview with Dr. Alexander Niculescu. He is the founder, chairman, and CEO of MindX Sciences. Dr. Niculescu was trained as a researcher and clinician at the Scripps Research Institute and the University of California at San Diego. He is currently a professor of psychiatry and medical neuroscience at Indiana University School of Medicine. He's also on the staff of the Veterans Hospital in Indianapolis and completed an executive MBA at IU Kelley School of Business. Dr. Niculescu is a recipient of prestigious national and international awards in the field of psychiatric genomics and is internationally known for his work on precision medicine for mental health. Dr. Niculescu, welcome. We're so glad you're here. And as you know, my son, Walt, died from treatment-resistant anxiety and depression after a 20-year struggle. He died by suicide. Walt took a genetic test the year he died that revealed what his doctor stated was a faulty fight or flight response, but sadly, the medications prescribed didn't resolve his condition. Our hope is through our interviews and advocacy outreach, we can educate the public on the importance of funding research in genetics, epigenetics, biomarkers, and precision medicine with the hopes for curative therapies. We want to thank you for your efforts in this field and really appreciate your time. So thank you so much.
Glad to be with you. And, I hear stories like that all the time, and this is why we're all fighting the same good fights together. So glad to be here and to share some of our thoughts and work with you.
Yeah, I've really enjoyed looking over your research and your websites and things, and we were so impressed. You were the first one that we reached out to because we were like, we really did want to talk with you and speak with you about your research because it is so promising. So we were thrilled that you accepted. So thank you again. We were wondering if you could explain to Waltz and the public what your research findings mean to people suffering from serious mental health conditions.
So there are three aspects to our research. We want to be very pragmatic and do things that can start helping people right now, as opposed to doing things that may be promissory or exciting over the long term. We have 2 decades of academic clinical research that went into some of the things that we're rolling out to doctors and patients right now as tools that can be used. And the research that we did was focused on 3 areas. One was just getting a better grasp of the diagnosis of what somebody is really suffering from. There's a lot of imprecision in psychiatry. I myself am a practicing psychiatrist. I still see patients a couple of days a week, patients with complicated cases, and I can see the need for being more precise in terms of classifying people. And what we've done is we've developed better instruments, better questionnaires over the years that can track people in a quantitative way in terms of their anxiety, mood, stress levels, psychosis, and so on. And those instruments were tested against existing psychiatric rating scales, which are a bit sort of more broad and imprecise. These were sort of very quantitative type of instruments. And then after we've done all this work, now they are part of an app called Life and Mind, Life X Mind by MindX Sciences. So people can track at home in a quantitative way, almost like with a Fitbit and so on, their levels of mood, anxiety, and so on, which is very important because that can really help their clinician establish the proper diagnosis. It's one thing, for example, if somebody comes to an appointment and you ask them, well, over the last 3 months, how has your mood been? And so on, and they have to remember how it was and so on, and they don't have a number for it. It's another thing if they bring at the appointment or email the clinician, data that shows, their mood has been up and down. So it's not just depression, it's a bipolar disorder. that's treated very differently from depression. So, for example, a lot of depression that's labeled as treatment resistance is, in our experience, actually bipolar disorder that's not recognized. People are treated with antidepressants that make them worse, make them more agitated and suicidal. So, knowing just what you're dealing with is very important. So that's the first step: having a better grasp on what people are suffering through quantitative assessments. And now that's part of an app that's widely available. People are using it and can track things at home and can share that with their clinician. It's all confidential. It's all on their phone. The company that I founded, Mindex Sciences, doesn't collect any of that data, doesn't monetize it, doesn't sell it. It's all on the patient's phone. The second step was we also need to have a better matching of patients to treatment. So for that, we developed a blood test. Currently, we have blood tests for 6 indications being rolled out and available to the public, where so-called biomarkers in the blood, which are biological molecules that vary with disease severity with response to treatment, are used to provide some objective information about somebody's severity of illness and to match them with the right medication. And these are existing medications, but there are many medication choices out there. So what we wanted to do was to match people to existing medications based on their biology, but based on their biological profile, based on their biomarkers. Yeah. So that's sort of one of the main things that these blood tests do. They match people to medications as opposed to having this trial and error process. The second thing that they do is, since you have an objective score based on the panels of biomarkers, as a clinician, you can see objectively if people are responding because the score of the blood test changes. You do it at baseline, you start a treatment that matches their biology, and then you repeat the blood test and see that their biomarker score changes, which means in the right direction, which means that they are responding to the treatment. So that's a second important part of our efforts. And then the third part is trying to help development of new or better medication. And again, there you can do something immediately to help people, and you can do something more long-term. The immediate part is that there are existing medications that are being used for other things, such as cardiovascular disorders, diabetes, and so on, that based on our research and biomarkers could be repurposed, could be used right now for some of the mental health symptoms and conditions. And that's sort of an easy, immediate thing, or at least easier and more short-term thing, because those are medications that are already on the market, they're already approved for human use in other disorders, and it would be just an off-label use or doing some clinical trials to use them immediately. Mm-hmm. And then the more long-term thing, in the third leg of the stool, the drug development part, is that we want to collaborate with pharmaceutical companies to help with their clinical trials, so they have some objective ways of enrolling people in trials, seeing who responds, and so on, as opposed to the current way of doing clinical trials, which is in psychiatry has been very unsuccessful, which is you enroll people just based on some paper questionnaires and, see,
right,
whether they meet those primary endpoints or not. So those are the three main things that we've done in research for a couple of decades. And then over the last 2 years, we formed a company to take some of those things out there so that they're available to doctors and patients. And the company Mindex is now functioning up and running.
Yeah, that's a lot of long time that you've been researching this, because, I think so much in the public, people don't even realize these types of things are out there or, available to them. I understand that there are some financial barriers right now, but with hopes, things can change in the future as far as that goes, as far as testing and things go. In terms of the public, how would you rate public awareness? And I kind of, hedged on that a little about, or brought that up, recent advances in epigenetic research. What do you think about the general public? Your own take on that?
So having sort of been involved in this field for a while and been there at its inception, the field of precision medicine and psychiatry and so on, I would say that on our side, as researchers, as as people who develop these things, it behooves us to not give false hopes. So when a study is done, the way my group has conducted studies over the years, for example, is we discover something, but then we check it in multiple independent cohorts before we publish. We don't just want to publish something, have a headline in the newspaper, give false hope, and then there's no follow-up or it doesn't pan out. And I think that's something very important in terms of how the science and research needs to be done. So that's on us, on the researchers to do that. Mm-hmm. Now, it's also on us to, when we do have something solid that we have verified and can be of practical use, to go out there and tell our story to the media so that people know about it, just like, and through various approaches now that you have podcasts, you have venues like yours, foundations, and so on, so that people know about it, and other clinicians who are not researchers know about it, and they start using it and provide feedback to how useful it is in clinical practice, and additional data can be collected, additional studies that can be collected to substantiate, this is useful, this can save on, not only save lives, but save on insurance costs. So then, payers, Medicare, insurance companies see the utility of what's being done and so on. So in some ways, it's very novel in mental health. Mm-hmm. In other ways, it's a playbook that's been well known and well executed in other fields. So,
yes.
We want to make psychiatry sort of not just another because it deals with the most complex things, but like other medical specialties, something where it's objective, where you have tests, where you have, precise information, and where there is, reimbursement for those tests so people can access them and use them.
Yeah. I know that it is important to not give false hope. I know with my son, for example, not that, it would be a promise of a medication possibly working, and it wouldn't be, it would be let's give it a try. And then you would have that elevation of hope, and then it not work again and again and again. And that was pretty much what kept happening to him. I was wondering, what do you consider as the major obstacle in translating your findings into well-defined therapies for serious mental health conditions?
The main thing actually is diagnosing people properly, starting with the right assessment and diagnosis. And a major thing that we've seen in our research, in my clinical practice over the years, with all the clinicians that I trained, fellows, residents, medical students, generations of people, it's that, for example, that if you label somebody or diagnose them with the wrong diagnosis, you put them on the wrong medications that can make things worse. So something as not necessarily us not having the right medications, it's just giving people the wrong medications that's the problem, because it's not the wrong label. So we need to be much more precise and use as part of clinical practice existing, questionnaires or new questionnaires like the ones we develop, apps, things like that, so that we make really sure that what we're treating, so we give the right medications that will help and not make things worse. And a common problem that I mentioned is that a lot of people get labeled with depression or with treatment-resistant depression and are tried on 1, 2, 3, 4, 7, endless numbers of antidepressants that do not help them in the long term, make them worse, and make them suicidal. And if you actually track their mood carefully, you would see that actually they have bipolar disorder, not depression. And that's treated very differently. That's treated with lithium, with Depakote, with other mood stabilizers. Lithium is a very underused medication. It's great for people with bipolar disorder. It's great for people with depression, and it's one of the best things that we have in terms of preventing suicide. So even with the existing tools, if they were implemented better, we would have a bigger impact on patients. And this sort of mislabeling and which leads to sort of snowballing of wrong medication, lack of response, side effect worsening is something that we can make an immediate impact right now. Besides sort of the more long-term thing of
Right.
medications, better medications, just start with doing the right thing with what we have before we jump to sort of things futuristic.
Well, exactly. I mean, we do have to start with what we have because that's all we have, right? I mean, in a sense as well. And some of those medications
But we're not, Susan, we're not using the current resources. Like, how many psychiatrists in clinical practice actually measure things, with questionnaires?
Exactly.
Track of mood, keep track of anxiety, keep track of stress in a quantitative way that will really help them make the right diagnosis, as opposed to just seeing somebody and putting a label on them and saying you're treatment resistant or you're this or you're that. So
yeah, I do understand that as far as what you're saying. One of the things that I have found that I know are some of these medications, they do help with this, but there's also the side effects that some people don't like. I mean, some have sexual side effects, weight gain, fuzzy-headed feeling. And so that can sometimes contribute to, even if it is the correct medication, the person not wanting to stay on it because they will say things like possibly, I don't feel like myself anymore. I feel like just zonked out. And so I understand that it is really, presently right now, we use what we have. But that's the hope for eventually, even possibly other types of medications
but even there, I agree with you. And we see that all the time. But even there, with existing medications, the reason why they have side effects is that they are used at high doses and so on. So you can get away with using much lower doses of existing medications that do not create side effects. Most side effects are dose dependent. They occur at higher doses.
Yeah.
If you use the right medication for the patient, and if you use combinations of medications that work well together as a team, give synergistic benefits and mitigate each other's side effects. So again, what's currently occurring is not only the use of the wrong medication for the wrong diagnosis, but the use of high doses of medications that lead to side effects, and then the patients obviously don't want to take them. It decreases their quality of life, it impairs them, and so on. So when you use the wrong medication for the wrong diagnosis, they are not responding. So you keep pushing the dose,
Pushing the dose. Exactly.
Side effects. Or even if it's a good match, if you're too aggressive with the doses, they'll have side effects. So it's good to sort of dial things down, have lower doses, and match them with other medications that, again, at lower doses. We call that rational polypharmacy, as opposed to irrational polypharmacy, where you just pile all sorts of things, throw the kitchen sink or something because it's not responding, and so on.
Yeah, that makes sense. Thank you for that. I appreciate it. Something I was wondering, could you kind of explain a bit about, I mean, in simplistic terms, like biomarkers, like a change that you see, just as an idea for us?
Yeah. So all of us have a blueprint, our DNA that is a blueprint for all of our genes, and then genes and environment lead to gene expression. So we have this blueprint, but the genes get expressed more or less depending on environment, depending on medications, depending on stage of life, and so on. And what we decided to do, instead of just looking at the DNA, the blueprint, which doesn't change, we wanted to look at the levels of activity of genes, how much they're expressed or not, which is dynamic. So you can see how sick somebody is, how they respond to treatment, and so on. So we looked at the RNA, which is made of the DNA, and which corresponds to how active a gene is. And we started first with all the genes in the genome, and we narrowed the list down to a handful of genes that are reflective of disease severity for the different disorders that we studied. So Minded Science is currently offering tests for mood disorders, for pain, for stress, for memory disorders, for suicidality risk, and for longevity. And we have other disorders that we are preparing to roll out tests in the next year or so. So these tests are, we also wanted, things that can be used by clinicians, can be used in any setting. So if you propose, you can't do a biopsy on the brain as a way of assessing somebody. It's not like in cancer where you can do a biopsy of tumor. No, biopsying the brain is not an option. Might never be an option, or it might be, but it's very sort of invasive and essentially non-feasible. Even spinal taps, if you look for markers in the spinal fluid, people are not like super enthusiastic about getting spinal taps. They are complicated, side effects, things like that. But then, we wanted to see, can we find something that's, easily accessible in the blood? So we started 2 decades ago, and it wasn't clear at all that something would be possible to do. So we did the work, and we did find things that track disease severity in the blood. We explained the whole process on our website, both the academic website of my group and the company website. So if people go to mindexsciences.com, there's a tab there where there's an explanation of how we did the studies and a video of that and so on that people might find useful. Provides more detailed background on this. But essentially, we were able to develop something that's very simple in any setting. You can get a blood sample just directly from brain to a special tube that specializes these markers, and then goes to a lab that analyzes the data. Then a report is provided to the doctor who ordered this, and they can use that report to match people to right treatment and to objectively measure how they respond to treatment.
Yeah, that I viewed that video. It's really good. Yeah. I was wondering, how do you think we can make this, these tests and things more available?
There are 2 barriers that we've encountered. One is obviously this idea of people knowing about them. So I'm happy to be speaking with you. Whenever we have a new announcement about the test or a publication, so people are aware about it. So awareness is one thing. The second, and clinicians also need to be aware that people who are treating patients, that these things are available, that you should ask them how they help you and stuff. So we're doing our part to educate, and we need to do a better job of educating people, raising awareness. The second part is financial. These tests are not sort of inexpensive tests. So on our side, we're working to sort of bring the price down, but people also need to be aware that these tests are very similar to tests that are being done, for example, in cancer, so-called liquid biopsy. This is a liquid biopsy for the brain. We've deliberately priced it less than cancer tests, but for this to be sort of feasible and for us to be able to offer these tests, there is, a price involved. Otherwise, there's no, without sort of having the ability to do the work, we cannot help the public. So what we're trying to do, we're cutting costs as much as possible on our side so people can have access to it. But people who are doing the work. So we're looking at how can we get Medicare reimbursement for the test? How can we talk to insurance companies and make the argument that look, this blood test is cheaper than a day of hospitalization. So if you get somebody on the right treatment, not only are you changing their destiny, saving life, potentially improving the quality of their life for them and their family, but as an insurance company, as a payer, saving money because, otherwise they'll get hospitalized repeatedly, but all sorts of costs, 3, 5, 7 days in the hospital and the test. So we're
is there needs to be like more FDA like a process through FDA or things like that? Or how is that? How does that work?
Not the way we currently have the test, because the tests are offered in a CLIA setting. This is a laboratory developed test type of setting where you just provide information to doctors based on what you do in the lab. You're not making the diagnosis. The doctors make the diagnosis. They use this information along with the clinical impression, other things to make a diagnosis. So because, these tests are not used to make a diagnosis and so on, there is no FDA approval needed. The claims that they make are very limited. And, this is sort of objective information that the doctor can use in context to guide their treatment and so on. Down the road, as, a lot of data accumulates, it could be that we may have a better handle on, things related to, how well the test relates to different diagnostic labels. And at that time, we will have a discussion with the FDA and see, whether this could be sort of bumped up, not just from our laboratory developed test that has provide objective information to doctors, but something that could be used as part of a diagnostic label and so on.
Yeah.
As we work with pharmaceutical companies, if they develop our test as a companion diagnostic to a drug, again, that is sort of an FDA type process. But we're very conservative, and we don't want to say, our test can diagnose somebody. We just want to say our tests, offer some information that taken together in context with other information, clinical information, other types of family history, etc., can help with diagnosis. And that's really the reality of it, how things work in practice. So.
Yeah. Okay. Yeah. I see that. Yeah. It would be awesome if we could get Medicaid on board and things, because
we're working on that.
Yeah. Could you describe like what the science means to this field? Like, what does it mean for people who suffer from mental health? Like today, 20 years from now, 30 years from now, your work.
Yeah. Well, I mean, we're essentially bringing psychiatry into the 21st century, which is a long overdue. It's a process, not just doing the research, but half of the battle will be disseminating it, getting it, into the hands of people, educating doctors about using it, and so on. Both aspects are important. Without good research, there's nothing to disseminate, and there's no credibility. But without doing an effort to educate people and disseminate things and so on, there's no adoption and practical use of those. So we need to do both. It's a process. I mean, not with any new development in medicine, it may take a while for not just the research to be done, but the tools to be rolled out, but also for them to be appreciated and adopted. So, and it could be that sort of younger generations of clinicians, of doctors who are more used to, contemporary approaches, are more, on board or willing to adopt these to abstract blood test, testing.
Right, than like previous dogma or something that they have been following.
And then sort of maybe generations that are used to a certain way or previous way of doing things and so on. Also, there are a lot of people of a certain age who are very sharp and very contemporary in how they do things, and then
kind of willing to think out of the box in a sense as well, like and move forward with it.
Not necessarily willing to think out of the box, but being sort of young at mind and looking at the evidence and adopting new things, as opposed to having that sort of just go do things with the way they've always been done. And looking outside your field, so it's new in psychiatry, but if you look at cancer, everything is based on precision medicine, right?
Exactly.
Right, chemotherapy based on the molecular profile, you stage things, you help with diagnosis based on that. we should do the trainings like that.
Yeah, yeah. I was wondering, using the test insights with the existing drugs, of course, is a leap forward. But do you feel like curative therapies will eventually be an extension or a next step as far as that goes?
So the word curative is I like more the word where sort of you restore normal quality of life and you sort of have people not be hampered by whatever they have. I mean, some of these things in effect will be curative, but the way to look at it is that it's a lifelong managing of things, just like with diabetes or with other sort of high blood pressure and so on, and that you take a combination of lifestyle factors, medications, other interventions to manage your condition, do things, and to live a normal life and so on. So it's all on a spectrum. So I view it more about giving people sort of normal lives, unhampered by mental health problems, as opposed to sort of making a big deal about curative. It's not you do something and that's done forever. Something that's a lifelong sort of management, just like you manage your weight, your blood pressure, diabetes. It's a lifelong process of taking care of things. So,
I guess it was, yeah. I mean, I guess in my mind, I was thinking a little bit about the idea of, for example, monogenics, monogenic, how they're looking at like cell therapy or things like that. I understand that this is polygenic and it's way more complicated and there's so many factors. I mean, I don't really understand it. I'm just, I don't want to think that I understand it, but I mean, from what I can understand.
I mean, nowadays we can do genome edit, right? So
right.
And with medications, we can dial up or down levels of gene expression. So, genome editing is still something that's, I think, for humans, it's relatively far into the future. It's being used initially just for like very monogenic or very defined life-threatening conditions. The benefits outweigh the things that are very subtle with the changes in many regions of the DNA, you're better off managing the gene expression levels with medications and lifestyle. That's what we're doing.
Okay. Yeah. I'm having a little trouble hearing you all of a sudden. Maybe it's my.
Yeah, can you hear me now?
Yeah, I can hear you better. So thank you.
I think I was mumbling. So genome editing, not yet, and it's hard because these are very sort of many regions of the DNA are involved in these conditions. But regulating gene expression and the disease biology through medications and lifestyle changes is doable right now, and I think that's where the focus should be. For now.
Exactly. Yeah. For where we are at right now, I understand that. I was curious if you're working with any advocacy groups or as far as that goes. Or...
No, I mean we're working with everybody. We're sort of open to everybody, and as an academic, my research has been well funded by the NIH, by the VA, and now we're at the company side. We're talking to investors about fundraising so we can continue to do this work, expand it, have these tools rolled out at scale. They're already being rolled out, but we need funds to roll it out at a much higher volume to all the people who need them, who are asking about them, and so on. I think there are many passionate people like you, like others who are involved in this space, and we're glad to work with everybody who wants to.
Yeah, we would love to push some of your work out there, if that would be okay, as Waltz, and also.
We're all fighting, as I said, the same good fight.
Yeah, exactly. One of the things that we're doing is meeting with Congress, and we've met with Congressman Raskin and others in hopes to have a mental health moonshot. As we know, like in 71, they started that the war on cancer, and then so much has happened from, in 50 years. And it feels as if we're just really decades and decades behind, what they've been looking at. And, it's impressive to know that you've been working in this field for a while now and accumulating research. And so our hope is that, we have a push, and we meet with different congressmen and senators, we're hoping to eventually, create this mental health moonshot that we know that we need. It seems as if it's been exposed through, as we know, COVID and things. It's kind of pushed it a little bit further as far as, kind of making more demands and things for this health services and things. So, and hopefully we will actually have more, targeted types of medications and things, because I know one of the really difficult things is, so for example, my son, it would be 6 weeks, as you're saying, 6 weeks on a medication to even see if it works. And you're not even really sure if it works. And it could take even longer if it works. And then, like you say, sometimes they will up the dosage. And then there's, even additional side effects, or, some people don't tolerate certain things. And it is really tough out there. And knowing that my son tried like everything, and I think that I was curious, just out of top of my head now, thinking like for so much, I understand that mindfulness and exercise and art therapy and things, are wonderful. My son taught yoga. He practiced mindfulness. He kept a gratitude journal for 10 years. He exercised. He ate correctly. He tried a myriad of different medications, including bipolar medication, even though they said that, he was not bipolar. They tried that. And he just still, it just seemed as if he could not find the help. And some of these things, I think, can cause additional shame and depression for people, as they feel as if, well, other people can do it. How there's kind of like a push that, if you just do this, it's mind over matter. And some of that is still, really in people, pull yourself up by your bootstraps and you can get this done. Even though there is this information out there, we're still meeting so much resistance.
Yeah. No, we call that the invisible limbs. People sort of walk around through life, live through life with all these sort of different things that are holding them back, and because they're not visible, people don't know about them, and they get frustrated with them, make demands on them. So physical limiting to push somebody to do something without to correct it. So with our tools, we want to sort of push, help people understand this visible link, and then match them to the right prosthesis, so to speak.
Right. Yeah. We're hoping that will really help push away the stigma that we have, because they'll say, here it is. We can look, we can see it, in comparison to it being, a weakness that,
comes out of our research, of the clinical practice, of the work that we did at Mindex is biomarkers, is that, lithium needs to be re-examined, rediscovered. Low dose lithium, not high doses that give side effects, but low dose lithium is a terrific medication for people who are depressed, agitated, suicidal, anxious. So we have a lot of.
And it's been around a long time. I mean, we know a lot about it.
I think it should be used more. I think that that's something that where doctors, if they look again and try people adding it to existing treatments, low dose lithium as a foundation for providing good brain health is something that will make a huge impact immediately. Yeah. As to government efforts, I think they are important. It's like with space, right? So you have NASA, and then you have SpaceX doing, working together and so on. You need both.
Yeah.